Good evening and welcome to another edition of What's Happening. I'm Elliot Margolis and I'm soloing today because of a couple of health issues. We've got George and Gail on the cameras, so I'm here by myself with my guest. Before I get into my guest, however, I have a couple things that I wanted to talk about. Number one, you know how when something happens and it doesn't go the way you want it to, people complain. Well, this is not a complaint. I want to congratulate the Beverly Department of Public Works. They did a great job plowing the snow for this last storm. And instead of complaining about it, I want to thank them for doing such a nice job. That being said, now I'm going to get a little cranky. I'm cranky because when you look at people like George Michael, Prince, Carrie Fisher, very, very talented people, extremely talented people. They did a lot of great things and great entertainers. But my question is this: why is it that we idolize them for what they've done, but we don't criticize them for what they have also done, which is get into drugs? Drugs shorten their lives. This could be a great learning tool for our younger people and middle age, probably older too. It could be a learning tool to say, look, George Michael, phenomenal talent, killed himself because he went into drugs. Isn't that a shame? And that's what we need to prevent from happening. And if we use it as a learning tool for the kids, they are role models. And what you want to do is teach people that their role models did something wrong. That's why they died so young. And maybe that can help us with our, with our drug problem. That in mind, I will introduce our guest, Dr. George Beilin. Now, I asked George for a bio, and it's only a half-hour show, so I can't read all of it because won't leave me enough time for questions. But he is a seasoned licensed psychologist in Beverly who has over 38 years of clinical and educational experience counseling children, adolescent adults, couples, and families. One of his present interests focuses on helping those individuals coping with particular medical conditions, in particular chronic pain. His office is here in Beverly, and I do need to note that Dr. Beilin's thoughts and opinions about chronic pain do not reflect those opinions necessarily of Leahy Hospital, given that he's not a staff member. Welcome, George.
Thank you.
Now I can put my phone down. Okay, George, you heard what I just said about these people.
Yeah.
We know that there's an awful lot of people in Beverly and the surrounding communities who have cut their lives short because of the opioid epidemic. How do you deal with that in your practice? Do you talk to people about getting involved in drugs and why they shouldn't, or why did they get involved in drugs? How do you work with people like that?
Well, I can't speak for the popular one, the extremely popular ones, the Hollywood ones. But I would say that a good fair sample of people who come to see me are referred because of coexisting disorders, like having some kind of alcohol or chemical dependence, and a dual diagnosis of a psychological problem, such as depression, which is very highly correlated with this kind of condition, or post-traumatic stress disorder, which is another one. So a lot of times what you see is the degree of self-medication going on. People using opiates. I don't really see many heroin addicts. I mean, that's really for methadone clinics and detox places. I don't work there. I mean, I'm in private practice for a long time. the ones that I really want to focus on are the ones who have chronic pain. And that's why, want to discuss that more so. But,
Right.
but the incidence of getting into opiate dependence, for example, like for teenagers and young adults, which is a high incidence, which has nothing to do with chronic pain, is terrible in and of itself in terms of self-medicating due to multiple reasons. I don't know if I answered your question, but that's...
Yeah, you sort of answered the question, but I mean, okay, so you've got two different types then. You've got pain management.
Yes.
So, all right, somebody's in pain, they get drugs from the doctors, and then they get hooked on them. How does that, first of all, how does that happen? Don't doctors know that they can only do a certain amount, or is everybody so different that you don't know if you give somebody a week's worth of pills, are they going to get hooked, or is it because they say, gee, I still have pain and give me another prescription type of a thing? I mean, how do they get hooked on these drugs? And then the next question will be, how do you get off of them?
Yeah. Well, let me just say, many people with chronic pain do not necessarily get hooked. As a matter of fact, Governor Baker, in his address to, initially and then formally came the Baker Bill, identified with the input of the American Medical Association, or the Massachusetts Medical Association chapter, the distinction between people with chronic pain and those who are self-medicating for other reasons, which does not mean that people with chronic pain don't get hooked, okay? As a matter of fact, the sad part about this is that, number one, there was an article in the Globe, I don't know if you saw it in the summer, that identified a particular statistic that was done in 2011 of a study of people in the United States having chronic pain, and it was verified by the writer that the same statistic is acknowledging now, and that's 100 million people. 100 million people in this country suffer from chronic pain. That's 1 in 3 people. We have a very serious crisis in our hands in terms of the number of people trying to cope with chronic pain. The issue about how they get on medications, I think that's our culture. Immediate gratification. You see all the prescriptions going on. What are doctors trained to do? They're trained to sort of give prescriptions, and nurse practitioners as well. I think what's happening now is what you're seeing is a somewhat anxiety effect, tremendous, almost on the verge of panic for a lot of doctors, and I'm talking about primary care physicians especially, who don't want to give prescriptions anymore and are delegating. Now, I may or may not be accurate about the Baker Bill, and that's why I'm trying to sort of clarify that. I think I sent you a note about this, that in terms of prescription monitoring, it was my understanding that there was an implication that doctors in different specialties will be compared to each other in terms of how many prescriptions they're giving out for pain or whatever. And if you think about it, if that's happening, and this is what I hear as well from lunchroom talk or from docs and et cetera, is they don't want to prescribe more and more. So they're trying to sort of lessen the number of prescriptions more and more and delegate patients to chronic pain or pain management centers, at which point anesthesiologists, who are typically pain management people, professionals, are stuck with the dilemma of, okay, what are we going to prescribe, and are we going to prescribe as much as realistic? So there is a need. There's no doubt there is a need for some of these medications for people with chronic pain to some degree. But the key is, I think most people are realizing that that it is not the whole answer, for chronic pain. People often have a difficult time coping. First of all, they may have a dual diagnosis of, as I said before, depression or anxiety. They may have had a hard time coping, being resilient, thinking about other dimensions in which they can use, like insurance doesn't pay for yoga or massage or swimming exercise and things like that. They'll pay for a physical therapist. But I think bottom line is, I think you're going to see the reality that 100 million people have chronic pain. There's still going to be this concern about, like, how many opiates should they be getting.
What exactly is an opiate? Let's because people are thinking now it's more heroin than anything.
No.
What is an opiate, and why is it so addictive?
Well, I'm not a chemist, but the nature of opiates. I mean, it comes from the poppies. It's either original or synthetic, and the original is from the poppy seed. And so,
if I get a Bagel at Bagel World, I could be in trouble.
Yeah, you better be careful about the ones. Don't get a mixed one too. Don't get everything one. That's even worse.
Really? Okay.
Oh yeah, because you don't know what else you're getting on that. It could have fentanyl on it. But the issue with so you have natural opium that's being transmitted, to not to doctors per se, but to the dealers who are selling it, and now it's sad to say with fentanyl coexisting. This is a very scary thing. What I do want to say though is I can't tell you what the statistical evidence is that most people with chronic pain get addicted. I don't think that's true. I don't think, if it's carefully monitored, they don't necessarily get addicted. At the same time, I've seen a lot of doctors now very frightened about giving opiate medications in conjunction with, with other kinds of recommendations because of what I said before. And these people are frightened that they won't be able to sort of tolerate their pain.
Is there any other type of drugs that could be used besides opiates for pain management?
By the way, I just want to say the others are OxyContin and hydrocodone, and those are often synthetics of. I just said heroin, and there's opiate, natural, fentanyl. I mean, all the other ones are synthetic makeups of these. But I didn't get it. I didn't hear your question. I'm sorry.
Okay, now I have to think of what my question was.
Okay.
Oh yeah, I remember. Are there any other drugs that could be used instead of opiates for pain management?
Oh yes, there are many. I mean, like NSAIDs. Doctors usually try to start off with NSAIDs, which are like aspirin or Aleve or Motrin, ibuprofen. Then there are, as a matter of fact, tricyclic antidepressants. There's some, and then there's a medication called Cymbalta, which is, I think it's an SNSRI or something like that. That can be helpful for pain. But the key is for people with chronic pain not to stay focused on just medication as the answer. Okay.
What should they focus on? I mean, you're in pain.
Yeah.
And now you have to think of another way to get out of pain. So what kind of things do you do to get out of the pain or to break the habit?
Okay. Well, if you look at pain as multidimensional, that is, it's not just caused by physical causes. By the way, it's a very small portion of actual detection of a particular, for example, a slip disc or a rupture or or some other physical condition that causes pain, moderate to severe pain. A lot of times it's other stressors that can cause these kinds of things, coupled by psychiatric kinds of conditions. what you look for is a multidimensional approach. I call it a pain management lifestyle. Okay, the physical aspects can include physical therapy, which is, as a matter of fact, it's critical, I think, for anyone who has chronic pain to make sure and push for a treatment team approach, that they have a team approach. They have not just, they don't necessarily have to go to a pain management center, or they may, but that they have, for example, their primary care physician who collaborates with a physical therapist or a chiropractor, possibly a trainer, which I think is an excellent idea in terms of exercise. It's not a good idea to not exercise when you have pain, even though many people think they shouldn't.
Well, if you have pain and you exercise, that could create more pain, couldn't it?
Well, short-term pain is a long-term gain. I mean, I think if you speak to a physical therapist, or you speak to a chiropractor, I mean, or someone like that, I mean, you know, they'll tell you that, and even your primary care physician will share that it's good to actually be moving and exercising in certain ways, and doing stretching. Stretching is another avenue. But the key here is, I think, that opiate prescription medicines should not be the whole answer long term for people with chronic pain. By the way, that statistic of 100 million people, I think it's 35% have moderate to severe pain.
Really?
Yeah.
Wow. All right. So I know some people that are addicted to opioids. They have to go away for a certain period of time to a clinic to get a. It's incredibly expensive. Incredibly expensive, and it's really a very long-term situation. It's not like you go to this place for a week and you're all cured. And it costs more than what most people make in a year to go to these places for a month.
Yeah.
So the question now is, are there state and federal funds to help people like that? Because not everybody can afford it. And I'm just wondering if you can draw a causal link between people that want to get off of it, can't afford it, and then end up dying because of an overdose. Mm-hmm.
Well, it's a very serious question.
There's only 6 questions in there. So.
Yeah. Well, by the way, I didn't even add, sort of how humble I am, I didn't even add the other strategies, which is cognitive behavioral therapy, which I do, and mindfulness training, and stress reduction, and meditation, even spirituality, ironically, can be very helpful. Teaching people how to think differently about their pain. So I just want to sort of add that. I mean, obviously that's
right.
why I'm here. I mean, in terms of what I do as a member of a team. Well, you know, I think my understanding is 1 in 3 or 1 in 4 people in Massachusetts are on Mass Health. Am I correct on that? At least that's a statistic I heard from one surgeon and another from another doctor.
I know there's a lot of people on Mass Health, but I mean,
I don't know what Mass Health pays for.
Yeah.
I don't have the distribution of. You know, that's
but
a large group.
Is there state and federal funds that can help people pay the $20,000, $30,000, $40,000 a month for these types of clinics, and then you still have to go back every once in a while for you know, to a halfway house or something. It takes my understanding, and you can correct me if I'm wrong. My understanding is, and I won't hold it against you. It could take up to 2 years to really clean somebody from their addiction.
Yeah, I see it as lifelong. I mean, in terms of relapse prevention. And bear in mind, in terms of the issue of capitation, global payment, you know, the less treatment, the better. and it's less costly. So I don't think, as a prospective legislative condition, there is a need to keep people in these long-term programs. What they want is, for example, like detox right away if necessary, and then get into a treatment center, day treatment center. There's an excellent one here at Aston Gilbert, for example, the Discover program, run by Leahy Hospital, and or relapse prevention, outpatient, intensive outpatient. So I don't think realistically, because of the excessive amount of monies that have been put into these large places, except for very wealthy people, maybe like, sad to say, people like Whitney Houston or Michael Jackson, could go pay for these kinds of places privately. But I don't think realistically the government should be in that anyway, in terms of paying for expensive, extraordinary people's money for these lavish programs.
But isn't this a type of addiction? A lot of people who are addicted are not the Michael Jacksons of the world. They are you and I, the average person who can get addicted for whatever you say. One of the reasons is the say depression.
Yes.
And
self-medicate. Yes.
Yeah. So, I'd say I would have to guess that that's a significant number of people who are involved with opioids, and they can't afford $40,000, $50,000 a month.
No.
And so, where do they go? How do they deal with this? I mean, it's assuming they have insurance, I don't think insurance covers everything like that.
No, it doesn't.
So how do you deal? I mean, this is a real problem when you've got people dying on a weekly basis.
Yeah.
I heard a statistic today during the hearings for Secretary of State or Attorney General, take your pick, that 75,000 people a year die from opioids. That's a significant statistic. That's,
It's probably higher. I think it's even higher. I think certainly it was high in the state. That's what sort of contributed to Baker Bill.
They mentioned that somewhere around close to double the number of people that died in Vietnam.
Yeah.
So with that in mind, there's so many people that have this problem. How do you solve it?
Well, you first of all, again, education is critical for both physicians, which I think is a part of the Baker Bill, to educate about prescribing appropriately, even though they're still running scared and will probably not want to do it because of the comparative data statistical issue.
Well, are they scared because they could get somebody addicted, or are they scared because of their insurance rates going higher?
Both. You don't have malpractice support, malpractice insurance support for those taking risks. For example, anesthesiologists or pain management people don't get lower malpractice rates because they're going to take the risk, the greater risk of prescribing the medications, including methadone or whatever, than the primary care physician. So you don't have the legal, you don't have the insurance, and you don't have the legal backing for these people. So they're afraid. They're, again, on a federal level, especially. I've known multiple doctors who've been pulled, and all of a sudden, secretly, they're not working anymore. And you find out that, they were prescribing too many, opiates or whatever. So getting back to your question again.
Oh, don't do that to me, George.
Listen, we're at an age of presenile dementia, which is another topic in and of itself.
Yeah, let's move on to another question instead, because I think you must have answered that one.
Oh, I know what I want to say. It's like alcohol. For example, alcoholics. people dealing with alcoholism is lifelong, and it used to be like they used to stay in inpatient settings. Insurance would pay for like 3 to 4 weeks. Now they're in for like 3 to 4 days after detox, and they go out to an outpatient program. What's pressed is like AA or NA, or Smart Recovery is another one, and group support and relapse prevention strategies.
Is group support very helpful?
Extremely helpful. As a matter of fact, I think there's ironically 2 factors I think that make, to me, that are the most critical for like people who go to AA or NA or OA, for example. One is having sponsors, having the sponsors, knowing that you can call certain people if you really feel a craving. And the other, ironically, is, which was been proven, I just went to a Harvard conference last spring on this, is a belief in spirituality, a higher power. It's sort of sad to think that before, religion used to be people going to churches and synagogues and mosques, whatever, would find inner comfort. At the same time, now, all of a sudden, AA, NA, OA have become the new churches and synagogues and mosques symbols for belief in a higher power.
Interesting.
So, yeah.
Okay. I give you 2 minutes to tell us.
I'm not running for president.
No, I understand that.
Okay.
I understand. Thank you.
Thank God.
Thank you
Yes.
for that.
Yeah.
But tell us what you do exactly to try and help people like that are in this situation.
Okay. So it depends on where their
2 minutes.
2 minutes. It depends. One very critical thing is it depends on their motivation. Where are they at their level of change? Do they really see themselves having a problem, or do they are they coming because somebody else is recommending it? That's a critical issue. Then they get to the point of ambivalence, which is maybe I do have a problem, maybe I don't. Okay, I'm talking about stages of change. Okay, and if they're coming because yes, I have a problem, I'm committed to change, that's the best person coming. All right, and in that case, you're dealing with, and again, I'm looking at, whether someone's coming with a drug dependence or chronic pain. Okay, because they can be mutually exclusive. Okay, then we're dealing with relapse prevention, understanding their triggers, dealing with the support systems they have, their cognitive appraisal of their problem, why they're self-medicating, alternative ways to deal with their physical and/or emotional pain, learning resilience. Resilience is a big one.
Okay. Very interesting. It's a very complicated issue.
Yes. By the way, I wasn't going to tell you that I've seen many more liberals lately with chronic pain, but that's not true.
No, we keep politics out.
We keep politics out.
Yes, we definitely keep politics out.
All right, okay.
But thanks for mentioning it anyhow.
I know you would like that, but it's a lie, by the way.
Anyhow, this is another series of shows that our group is doing and what's happening to talk about the opioid situation, not only in the North Shore, but all over the country. We've had a few shows already. George, thank you for coming, and Dr. George, I'm not used to calling you doctor. We've known each other for more years than that.
Yeah.
But we've got more shows coming to talk about this show. We're doing a whole series on it. I hope it's educational for you, and I hope you learn something from it. And if you know somebody that's having a problem, please call somebody. Call some authorities. There's a lot of people that can help, but the most important thing is get help as soon as you can. Thanks for watching.